Good afternoon. Thank you for coming to the first talk in the pain series. I figured everybody would be interested in that because it applies in one way or the other to us. So I'm sure a lot of us have personal reasons to come and also otherwise just to learn what it's all about. And that's what we are going to do today. I want to first introduce my co-facilitator, Dr. Roger Fillingim. He is the director of the University of Florida Pain Research and Intervention Center, Center for Excellence, Pain Research and Intervention Center for Excellence, which the acronym is PRICE, much easier to say and remember. So he's the director of PRICE and a distinguished professor at the University of Florida. So I went to him, and I'd had him come earlier to give a talk to the retired faculty group. So I went to him and I said, I need to find some speakers for the pain series. And do you have some suggestions? So he gave me a whole list of names and I said, okay, I'll start writing to them. He said, nah, I'll do it. So he wrote to them, got them, organized the whole thing, and I get credit for it. Thank you, Roger. This was the easiest course that I've had to put together, Roger. Roger is also the first speaker, as you can see there. The title of his talk is, This Will Hurt Me More Than It Hurts You. So now I'll introduce him to you as the speaker. I've got a long CV for you.
Oh, no.
Okay, I'll keep it brief. As I mentioned, he's a distinguished professor at UF in the College of Dentistry, and he's the director of PRICE. However, he's trained as a clinical psychologist, not a dentist. And his research is based on investigating the biological and psychosocial contributions to individual differences in pain. In other words, he looks at the influence of gender, male versus female, and ethnic differences and age differences in the perception of pain. So why do different individuals feel the pain, same kind of pain, differently? He has been continuously funded by the NIH since 1994, including a current Merit Award. Is it still current? A Merit Award is the highest research award you can get from the NIH. So his is from the National Institute on Aging. He has published close to 500 papers. So you write one every day. And has delivered numerous plenary lectures and keynote talks at international conferences. He has provided national leadership, serving as the president of the American Pain Society from 2012 to 2014. And he has served on the Department of Health and Human Services Interagency Pain Research Coordinating Committee. He has also served several different positions with the NIH review panels and editorial boards of the pain journals. I won't go into details. He has received numerous awards. And at UF, I should mention, I'm just skipping now. He wants me to keep it brief. At UF, he has been named the UF Foundation Term Professor in 2019 and 21, and also in 2017 to 2019, so twice. He's an elected member of the Academy of Science, Engineering, and Medicine of Florida. He has received the Distinguished Service Award from the American Pain Society, and his interest also is in mentoring young researchers at the beginning of their careers. And so in that regard, he's received the Postdoctoral Mentoring Award from UF. He has served as president of the American Pain Society, and he's received an Investigator Award from the Pain Society, also American Pain Society. So he's a very distinguished and accomplished researcher and speaker in pain. So please welcome Roger Fillingim.
Thank you so much, Pushpa, and thanks for having me here. Is that a little bit loud? Is that okay? Great. So our center is excited to present to you some of the work we're all doing on pain and hopefully present it in a way that you find useful and informative. And you're going to hear several talks from colleagues. You'll hear, I believe, our next speaker is Dr. Cruz Almeida, and she'll talk specifically on how pain and aging interact. But we'll also have talks about back pain, and we'll have information on how new drugs get developed and on different integrative treatments. So hopefully you'll find it useful, and we're definitely excited to be here. Let's see here. We might just need to, there we go. And the reason we're talking about pain is because it is big and bad. Chronic pain is arguably the most common and most expensive chronic health condition in the developed world. It's been estimated that chronic pain affects as many as 100 million people in the United States. And the societal costs of chronic pain are greater than the combined costs of cancer, AIDS, and heart disease. So chronic pain touches many, many people. And that's why our center and our colleagues at the University of Florida are so invested in researching pain and in ultimately hoping to find better treatments for pain. There we go. And let me just give you an example of some information on pain. This is not necessarily good news, but I'm calling balls and strikes here. I'm not trying to put a spin on it. So what you see here are two graphs, men on the left, women on the right. And those lines are the proportion of people in the population who report having pain. And you see different age groups. And so one thing we can discern from this information is that as we age, more of us experience pain. That may not be terribly surprising to many of you in the room. The other thing you see is that the graphs on the right generally show higher prevalence or frequency of pain than the one on the left. And this is a consistent finding that women experience pain more often, or at least report pain more often than do men. Now, the other thing that's depicted in this graph is that the proportion of people in the population with pain is increasing. So it was bad enough back in 2002, and there's been a substantial increase at all age levels in the proportion of people who are experiencing pain. So we have a public health concern that's worsening, and so we need to devote more effort to managing pain effectively. And so what I'm going to be talking to you today about is what I call individual differences in pain. And we can talk about pain, but pain doesn't exist in the ether. Pain exists in people, right? And this is where individual differences come from, because people come in all shapes and sizes. They differ from each other in many significant ways. And many of the ways that people differ from each other seem to affect how we experience pain. And that's what individual differences in pain mean. Now, a specific definition of individual differences in pain is here. It is between person differences. So you and I experience pain differently. And that's not because your injury is worse than mine or my injury is worse than yours. Even if we have an identical injury, we experience pain differently. Okay? That's the definition of individual differences in pain. And I'll give you an example. But first, let me talk about how we measure pain, right? Pain is a subjective personal experience, and that makes it, by definition, difficult to measure. Okay? The gold standard for measuring pain is for me to ask you about your pain. Self-report is the gold standard. In fact, every other measure of pain is stacked up against whether or not it corresponds to somebody's self-report. So what you tell your doctor about pain is the gold standard. You're the expert on your pain. There are behavioral observations we can make. You probably have seen people, let's say, limping or guarding or grimacing. There are behavioral indicators of pain. There are also some physiological changes that often occur in the presence of pain. When we're in pain, our blood pressure and heart rate may go up. Our skin, our hands may get sweatier. And there are certainly brain responses. If we put you in a scanner, we can look at how your brain activity is going, and we can tell when people are in pain and when they're not. But many of these other indicators aren't specific to pain, like take blood pressure, for example. Lots of things make blood pressure go up. It's not just pain. It could be stress, it could be excitement, it could be exercise, and so on and so forth. And so when we measure pain, our number one focus is on asking the person about the pain they experience. And when you provide good instructions, people are remarkably good at telling you about their pain. Okay. All right, so let me tell you what individual differences in pain are. And I'll explain this graph here. Just focus on that first column right here on the left. These are ratings of pain after gallbladder surgery. And you may not be able to see them, but there are lots of little dots on this graph. All these little tiny dots are individual patients' pain reports. And they reported their pain from 0 to 100. Now, in a typical paper, what you would see is what's the average pain of people after they have their gallbladder out? Well, it's about 50 out of 100. But that's not the story here, right? The story is you had a very fortunate handful of people who reported no pain whatsoever after their surgery. They said 0 when they were asked about their pain. You had a less fortunate group of people who reported 100 after their surgery. Same surgery in everybody. And then you have people occupying every point on that 0 to 100 scale. So if you were to ask your doctor, how much pain am I going to be in after my gallbladder surgery? The honest answer, it's going to be somewhere between 0 and 100, okay? But we don't know how much. We don't know which dot you're going to be. So those are individual differences in pain. One critique of that kind of statistic is these people had different levels of disease in their gallbladder, and they were on different medications, and the surgery goes a little bit different in everybody, and the post-surgical medication works differently. So some of that must be due to all these other factors, and that's true. And so what we do is we bring people into the laboratory and we use standardized stimuli, heat, cold, pressure that are carefully calibrated so that we know the stimulus that's producing pain is the same in everybody. And so any difference in the pain that's reported must be an individual difference, must be due to something that's causing that person to experience pain differently. And so here's a study we did years ago. 321 people come into the lab. We induce pain with 118-degree heat stimulus applied to their forearm. This doesn't cause a burn, but it does cause pain. We asked them to rate how painful that was from 0 to 100. Every white line, very thin white line on this graph, is the rating of one of our participants. And you can see the average rating in red there was almost 72. So it was pretty painful on average. But again, we have a group of people who found it barely painful at all. Their pain ratings were so low as to be somewhat negligible. And behind the captioning there, you see a group of people whose pain was 100. Same exact stimulus, wildly different pain responses. Those are individual differences in pain. This is not a fluke. These are the rules of the game. Okay. And this is why I believe Dr. William Osler, one of the fathers of modern medicine, said it is much more important to know what sort of a patient has a disease than what sort of a disease a patient has, recognizing that that person brings with them characteristics that greatly influence how the disease is experienced. So maybe you're convinced that individual differences in pain are real. Well, why would somebody study these? Well, there are really three reasons. Number one, they reflect pain mechanisms. And when I say pain mechanisms, there are a lot of biological, psychological, and social influences that impact how we experience pain. Individual differences are caused by those factors. Okay? And those factors are very interesting to study if you're going to understand pain better. Number two, individual differences influence treatment responses too. So the same medication given to two different people will impact their pain completely different. So we need to understand those individual differences too. And then as a researcher, if I ignore individual differences, they become noise in my study, and that noise undermines my ability to answer the questions I'm trying to answer. So there are many reasons to study individual differences. I'm really going to focus on the top reason, which is what mechanisms are involved or what factors are related to individual differences. When we think about individual differences in pain, we think about it in the context of what's called the biopsychosocial model of pain, which tells us that pain is not only a biological event. The very experience of pain is importantly driven by a combination of biological, psychological, and social influences. And if we really want to understand pain, we have to take all of those influences into account. And I'll give you some examples of that a little bit later. So there are a lot of individual difference factors. Some of the most commonly studied ones are demographic factors. How do men and women experience pain differently? How does age affect our experience of pain? How do people from different racial and ethnic groups experience pain? That may be because these are convenient factors to study. In most data sets, we know the sex and the race and the age of the people, and it's easy enough to put people into groups. But there are also important public health reasons because it tells us there may be large groups in the population who are at particular risk of pain. And if we want to improve pain in the population overall, we might do well to target those groups that are at risk for having more pain. There are biological processes. One example is genetics. There are many others. And then there are psychosocial factors, how we think, how we feel, the environment we live in, our cultural norms, so many different individual difference factors. And let me just start with the example of sex differences. Most types of pain, not all, but most types of chronic pain are more common in females than in males. And this is just a graph showing what my colleague called the excess prevalence. That is, how many more women than men have this pain condition on a percentage basis. And so you see that back pain, the excess prevalence was 4%. So let's say the prevalence of back pain is 10% in men and it's 14% in women. That's a 4% excess prevalence. You see, migraine is really substantially more common in women than in men. Musculoskeletal pain in general, neuropathic pain a little less so, and oral pain. And these are chronic pain conditions that we're talking about here. And this is just one analysis of this information, but it's a very common finding that women experience more pain than men. So when we bring people into the laboratory to study the actual perception of pain, we see similar findings. Now, let me just explain what this graph means. So we have brought over 300 people into the laboratory, and we have conducted several different types of pain tests on them. We've used heat pain. We've used ischemic pain by inflating a blood pressure cuff really high on their upper arm. We've used cold pain with ice cold water. We've used pressure pain. And we measure their threshold, that is, how much stimulation is required to first produce pain. And we've measured tolerance. How much are they willing to take before they say stop? So the higher your threshold and tolerance, the lower your sensitivity to pain. And what you see here, that the average score for the whole sample is 0. All of the blue bars, which are men, are higher than 0. All of the pink bars, which are women, are lower than 0. And that means that across every test we did, women were more sensitive to pain than were men. Okay. And we can, at the end, we can talk about why this might be. Now, the fact that some bars are big and some bars are little tells you how big is that difference? How much more sensitive were women than men? And you can see for heat pain tolerance, that's a pretty big difference. But for the ischemic pain, the difference wasn't all that big. I realize this is just one study, but having read this literature for many years, this reflects the overall literature. Maybe hundreds of studies of men and women in the laboratory, and when you average them all together, they look very much like this. So we have a greater burden of pain in the population in women, and when you bring women and men into the laboratory, women are more sensitive to various types of pain than men. So that's one individual difference factor. Race and ethnic group is another factor we've been interested in, and that's because there's a significant amount of clinical research that shows that individuals from minoritized groups, and in the US, the groups that have been studied the most are African American and Hispanic American individuals, and they are at risk for greater pain and disability. They're also at risk for undertreatment of their pain. And of course, these things can be related. If you have pain and you're not getting the treatment that you need, that pain could be more severe. And so our upload study, Understanding Pain and Limitations in Osteoarthritic Disease, has been going on for some time now. And we brought African American and non-Hispanic white adults who have knee pain because of arthritis. We brought them into the lab and we did some of these pain tests. This is heat pain threshold and tolerance and pressure pain threshold at several different sites. And it's the same kind of graph I showed you with men and women, where 0 is the average for the whole group. You can see non-Hispanic whites, their bars go up. Our African American participants, their bars go down. So across all the different pains that we created in the laboratory, our African American participants were more sensitive than our non-Hispanic white participants. And this isn't restricted to just the knee that hurts. This is no matter where we apply the stimulation on the body. So this is a general effect. Again, this pretty well reflects the literature that's been collected on ethnic differences in pain. You'll hear more about age differences from Dr. Cruz Almeida next week. I'll just touch on a couple of things, but there's a lot of interest in understanding how pain might change with age. When you look in the population, you can see the prevalence of chronic pain goes up as we get older. And that's also true for high impact chronic pain. So if you have chronic pain and it is affecting your ability to do daily activities, that too becomes more common as we age. So we need to understand how and why age affects pain. It can depend on the type of pain. I did want to make that point. For joint pain, neuropathic pain, lower extremity pain, it seems to keep getting worse as we age. For other types of pain, general chronic pain, it tends to increase until middle age and then plateau. And then, frankly, some types of pain become less common as we age for reasons that we don't completely understand yet. So the effects of age on pain depend, at least in part, on what type of pain we're talking about. And I'll give you one finding from the laboratory related to age, and it's our way of testing your own internal pain control system. Okay? And so the way we would do this is we would apply a heat pain stimulus to your hand, and you might rate that at 75. Then we have you stick your opposite foot in cold water. Okay? This sounds fun, am I right? And while your foot is in that cold water, we test the same heat stimulus again. And lo and behold, you say that's a 35 now. It went down by 40 points. And it may seem like we're just distracting you with the foot pain, but it's not that. We're actually turning on a system that starts in your brain and turns down the transmission of this heat pain, okay? And so that is an internal pain control system. And then after your foot comes out of the cold water, you feel the heat pain just like you did before. So that's how we test the functioning of the pain control system. My colleague Joe Riley at University of Florida did this with a group of younger, middle-aged, and older adults, and you see the younger adults get a nice decrease in pain. Middle-aged adults get a little bit of a decrease, and the older adults didn't get any decrease in their pain, telling us that something about that pain control system starts working less and less well as we age. And so when we think about the experience of pain, our ability to feel pain is influenced by two opposing forces. We have a pain transmission, pain amplification system, and we have a pain dampening or pain control system. And if those are in balance, it lets us feel pain when we need to, but not too much pain that it gets in our way. Okay, there's a healthy balance of those systems. As we age, we get better at amplifying pain and we get worse at dampening pain. And that can put us at risk for experiencing more pain. And so trying to restore this healthy pain control balance is one of the goals of treating pain. I mentioned biological factors. Genetics has been of great interest over the years, and it actually allowed us to start talking about individual differences again, right? Because if a genetic factor causes differences between people, then maybe they're real. So it sort of legitimized individual differences. And interestingly, everything has a genetic component. This is a twin study where they looked at the genetic contribution to political attitudes. And you may be surprised to know that your attitudes about property taxes and capitalism and the death penalty have a significant genetic component. Okay? And I'm not sure exactly why, but one thing that this has helped me realize is that when I encounter people who have frankly moronic political attitudes, I should be a little more sympathetic because they might have a genetic disorder, okay? And like genetic or political attitudes, pain is greatly influenced by genetics. And these bars indicate the genetic contribution to back pain, widespread pain, migraine, and even the types of experimental pain that I've been talking about. And so it looks like there's about a 30 to 50% genetic contribution to our experience of these different types of pain. So genetics are important. Pushpa mentioned I'm a psychologist, and so I should at least mention psychological factors. There's an abundant amount of research studying how psychological factors relate to pain. I'll just give you one example from our OPERA study, the Orofacial Pain Perspective Evaluation and Risk Assessment Study. And you may notice that I've used several acronyms in the presentation today. Among the skills you need in clinical research, the most important is the ability to construct an acronym, okay? And so we've developed a clinical research acronym program, and if you can move the little thingy there, it's also known as CRAP. And so if any of you would like to build your acronym skills, just let me know. But our OPERA study is very complicated. But one thing we did is we recruited a group of around 3,000 people that did not have pain when we met them, and they didn't have a history of facial pain. We were studying facial pain in this study. We recruited these people, measured lots of things, including psychological factors, and then we followed them for several years to identify ones who would develop facial pain during that follow-up period. And that's really important because we knew something about them before they had pain. So these could potentially be factors that might be causative in development of their pain. And one thing we did is measure psychological factors. And there are two sets of factors that we found were significantly related to future development of orofacial pain. There were global psychological symptoms like body symptoms, depression, post-traumatic stress disorder. And then there was stress and negative affect, how much stress people reported, how much anxiety they reported. And oftentimes we were measuring these things years before people developed their pain. So how somebody is functioning psychologically today can put them at risk for development of pain in the future. Exactly why that is, we don't know, but it's been a consistent finding in this and in other studies. And the other thing I'll mention, if we go back to the biopsychosocial model, it's not just that biological, psychological, and social factors influence pain, it's that they interact with each other to influence pain. So, for example, certain genetic factors combine with psychological factors to influence pain, or some genetic factors influence pain in different ways in men and women. And so you have to consider all the factors together. And I do at least want to mention pain treatment approaches. Okay. So we've talked about individual differences in pain and how they reveal the many different factors that influence pain. What does that have to do with pain treatment? Well, you can think of multiple categories of pain treatment. Some of you may have had such treatments or know people who have had such treatments, surgical, interventional, medications, things like physical therapy, massage, behavioral and psychological treatments for pain, integrative treatments like acupuncture, botanicals, nutraceuticals, those kinds of things. And then self-management approaches, things we can do for ourselves to manage pain, including nutrition and stress management and sleep hygiene. And for all of these different types of treatment, there is evidence of their efficacy for pain, that they do work to some degree and in some people. But first of all, different people respond differently to all of these treatments. And frankly, most of these treatments, even if they help pain, they help pain in a minority of patients that receive them. Okay? Even the most effective medications out there for chronic pain, they produce a clinically meaningful improvement in pain in a minority of patients who take them. Okay? And so one of the reasons for that is that multiple factors affect pain, and a single treatment often is not enough to address all of the factors affecting somebody's pain. So, responses to treatment are quite different across people. I've already told you that. And the treatments are targeting specific processes that cause individual differences in pain. Many treatments target, like medications, target a specific biological process. Okay? And if the person that's taking that medication has pain that's not influenced by that biological process, that treatment will not be effective. So right now, it's a lot of trial and error to match the treatment to the patient, because we're not very good at doing that a priori. We're not very good at knowing exactly what treatment you need until we try it. And as I mentioned, multiple factors interact to influence pain, and so single treatments are less likely to succeed. We need to do a better, more systematic job of combining treatments, medication and exercise and psychological intervention, so on and so forth. And where we want to get is where we can tailor the combination for each person, right? The ultimate goal would be to take a blood sample, to take all the information we have about you and your electronic health record, to feed it into some AI system, which scares me beyond belief. And then the AI system says, this is likely to be the most effective treatment regimen, right? That's the goal. That's why we're studying these things, but we have a ways to go before we get there. So just to summarize, pain is indeed a major public health problem. There are challenges in studying pain, one of which is everybody's so different. As I've mentioned, multiple factors contribute to these individual differences. And if we can better understand these individual differences, we're going to be able to diagnose and treat pain more effectively. And these are at least some of the folks from our center and some of the agencies who've supported our work. And I will thank you for your attention and take any questions you might have.
Could you talk a little more about putting the person in cold water and it changing the reaction to the heat stimulus?
Yes. Yes. So that is the most commonly used test of an internal pain control system. We call it conditioned pain modulation. It was originally studied in animals. By putting your foot in cold water, it sends a signal to your brain. Your brain then sends a signal down to your spinal cord to essentially clamp incoming pain from other sources. We call it pain reduces pain. Okay. Now, I'm not suggesting that if you're in pain, you stick both feet in ice cold water. We don't use this as a treatment. We use it to study how well somebody's pain control system is working. I would also add, it's not the only way of testing your pain control system. We have different pain control systems. One way to activate your internal pain control system is by changing your expectations. The placebo effect. If I give you an inert treatment and I induce in you expectations that that treatment's going to relieve your pain, it doesn't fake you out into thinking you have less pain. It engages brain networks that reduce the amount of pain in your brain. So there are different approaches to activating different pain control systems, but that's just the one we use in the laboratory most often.
I think that method is being used elsewhere. I'm trying to remember where I heard it, but they distract the patient with another thing. We're doing a procedure, say a dental procedure, and distract the patient and they feel the pain less.
Yes.
Kind of the same thing sticking. So I think it is being used in some instances. I can't remember the.
Yes, my colleagues in the dental school do use that. They'll grab your cheek and shake it when they're about to do an injection. Of course, they've almost always applied some local anesthetic first. So it is used in different settings.
Yeah.
Why does AI scare you beyond belief?
So that would be a long conversation. And it partly scares me because I listened to the wrong podcast. But I'll sum it up this way. The people who are creating it don't understand it, and many of them are scared of it. And if they weren't making so much money from it, they'd probably shut it down right now. That's my view. And I recognize that's a very glass half empty view. I think it has a lot of potential too, but yes.
And the politicians who benefit from it also don't want to regulate it. But chronic pain increases with age. And a lot of it is inherited proclivity. You didn't mention arthritis, osteoarthritis. I mean, it's just plain old wear and tear. When you get old, you know, your joints start getting worn out. How come you didn't mention that? You didn't mention osteoarthritis specifically.
Yes. Yeah. So the joint pain that on that one that keeps going up as we age, joint pain was there, and arthritis is the main driver of joint pain. And we're interested in arthritis. We've been studying it for many years. It does increase with age, but it's very interesting. If you take an x-ray of the arthritic knee, it doesn't tell you a lot about how much pain that person is in. Okay. In general, people with a terribly arthritic knee and people with no arthritis in their knee, the people with the really bad knee have more pain. But in people with arthritis, how bad your knee looks on the x-ray does not say very much about how much pain you're in, which is an example of individual differences, right? Because all of these other factors that I mentioned come into play, our genetics and our gender and our psychological processes and many other biological factors. So even though arthritis does increase with age, its effect on pain will be determined partly by the joint, but partly by many other factors that are part of that person's makeup.
You're speaking to a crowd at Okamic, which is an older population, but also living in an environment where there's a lot of social interaction, educational stimulation. But a lot of the aging population don't have the advantage of Okamic. They may be in a Medicaid-sponsored nursing home or something. I was just thinking of a clinical study because we may have a lot of diversions here that would make us less bothered by pain or the perception of pain than somebody's living by themselves in a poorly run nursing home. Is that a type of clinical study that would be of any interest to your associates?
Oh, I think that would be a fantastic clinical study. And it would be a great way to test some of the environmental factors that can really importantly influence pain. And they would influence pain at multiple levels, right? It would influence potentially how much inflammation is in your body. It would influence how your brain is functioning. There may be more physical activity out here. And so it would offer an opportunity to look at within the aging population how these multiple individual difference factors, biopsychosocial factors, are contributing to pain. That's a great idea. Yeah.
I have two quick questions. The first one is the gallbladder, were they open or laparoscopic? Because the pain difference post-op between those two procedures is tremendous. The other thing is facial pain. Are you talking about toothaches, TMJ, or trigeminal neuralgia? Because again, those are terribly different things, and I think lumping them all together, I don't understand that.
Sure. So the gallbladder surgery was laparoscopic in that study. In terms of facial pain, our OPERA study was focused on temporomandibular disorders specifically. We had a set diagnostic approach, so we didn't include trigeminal neuralgia or more acute toothache or other things. But you're absolutely right. You have to sort of disentangle those things.
Roger, thank you for your presentation. As a kind of a pharmacogenetics question, and that is, you've obviously shown a genetic predisposition to pain and pain appreciation. How about the efficacy of pain relieving drugs? Is that also shown familial aggregation? And would that be an important part of a history, which we're not taking right now, about how did your mom do and what were they taking?
Yeah, so genetic factors strongly influence responses to drugs. I think in the pain space, we're probably well behind the rest of the medical world. Tom, you know well the personalized medicine group here at UF. They've done studies where simply giving your physician information about one gene in your body can improve the pain control you get from whatever medication comes next. And it's because it helps the physician pick a medication that's more likely to work for you, and then that helps to control your pain more. But we need to do a much better job of expanding the number of genes we're talking about and the number of medications we're interested in. Yeah.
Hi, thank you very, very much. Enjoyed this. I have two questions. Well, one comment. The presentation didn't seem to hurt you more than it did us. But I'll accept that. My question is, could you expand a bit on the differences in pain thresholds between racial groups, between black and white, specifically in this country? Have studies like that been done in other countries where, for example, the whites would be in the minority or would be oppressed in the, pardon me, God, but in the same way that blacks are here?
Yeah. So there's been a little bit of work done on that. One finding that's relevant is, for example, with Asian Americans living in America versus Asians still living in Asia, Asian Americans show more pain and greater pain sensitivity compared to their counterparts who are still living at home. Now, part of that could be the challenges associated with being a minority person in a majority culture and whatever stress that may involve. Could also have to do with nutritional factors, because if you move from wherever you are and start eating a standard American diet, you're going to be worse off no matter what, right? And so there have been a few studies that have looked at that. I haven't seen many studies that have gone to other countries where whites would be the minority and compared whites as a minority group to the majority group, but that would be fascinating. Yeah. Yes. Yes.
I have a question. Whoops.
The men are not, men are men. And they don't want to maybe admit, generally speaking, that they have a pain or an ache or whatever. So I'm wondering how valid all that really is. So
that's a really important point, because I was very clear. Pain is based on self-report, right? And if men are underreporting pain, that will look like a sex difference in the experience of pain. There have been studies that have looked at that. When you ask men and women, who's more willing to report pain? Both men and women say women are more willing to report pain, right? When you account for an individual's willingness to report pain, it reduces the size of the sex difference, but it doesn't get rid of it. So that's one thing. Another thing is some of the studies have included brain imaging. So looking at brain activation, and there's a lot of overlap in how the brain in pain looks in men and women, but there are also some differences that may be important in producing differences in the experience of pain in men and women. So I think you're right that our gender roles can influence sex differences, but these sex differences are also shown in laboratory animals like mice and rats, and they don't have the same gender roles. They do have gender roles in their sort of hierarchical system. And then the last thing I'd say is one misinterpretation of the sex differences in pain is that women are experiencing too much pain and men are experiencing the right amount. There's no reason that men need to be the normative group in every study, right? And so I don't know who has the right amount of pain. And in general, women have a broader repertoire of pain coping skills. So it's one thing to experience pain. It's another thing to deal with it, right? In my laboratory, women have a broader repertoire of coping skills. And so that's important to keep in mind as well. But yes, thank you for that point. It's an important point.
I had a question and a comment, and my comment was related to Jeannie's, that anecdotally, with me, I mean, when my husband has a cold, it's like he's dying, whereas when most women have a cold, we just march on, but that's anecdotally. But my question to you is not a facetious one, but as studying pain, are you in pain? Are you able to better control your pain because that's your life work?
I am fortunate not to have chronic pain. I have occasional aches and pains like everyone. I may be a typical man because I'm a bit of a wimp when I'm in pain and may not cope with it as well as I could. I try to engage in preventive strategies to maintain my health and kind of keep warding off pain in terms of exercise and sleep and decent nutrition. But I may be more like your husband than I'd like to admit. Yes.
I've got two things, one anecdotal and another question. I am a clinical nurse specialist in high risk obstetrics with a doctorate in my field. I work in third world countries with the poorest of the poor. And I am a midwife. I do deliveries with no medication. I take care of communities who have no access. I just recently did surgery on a woman with nothing, and I never heard a peep out of her. So it's what you're used to, what your culture allows you to have, and what you think as a society, you're allowed. So these groups, and I've been in 67 countries, do not have pain medication. They have their natural environment, herbal medications that help. Now, this is a question that I wanted to ask as you talk about psychological and physiological. The pain physiologically goes from wherever to your brain. Now, if it's acute pain that you're going to be having with the potential of having a bit of a prolonged pain afterwards, are they now using anxiety medications along with this to help decrease the pain, anxiety to pain, pain to anxiety, so that people don't have to be on narcotics as long and decrease the risk of addiction if they start combining medications like this?
So are you talking about in the acute pain setting to
Yes.
sort of to address concerns about
right.
pain and prolonged
You're
pain?
going to have an acute amount of pain, say for a joint replacement or something, because what I've noticed when I've been around, their biggest concern is your addiction, but I don't see anything being done for anxiety, as part of leading into people having higher pain
Sure.
or prolonged pain.
Yeah. Dr. Logan has actually done work on anxiety and pain. I don't know that they're using anti-anxiety medications. There is some evidence from people like Dr. Logan that how much anxiety you have now while you're having acute pain will be a better predictor of how much pain you recall than how much pain you actually have. So anxiety is an important factor. More behavioral approaches to reducing anxiety have been effective in reducing acute pain. So that has worked. I don't think there's been a lot of interest in using anxiety medications because they too have some potential for addiction, like the opioids they're trying to avoid. But addressing anxiety in the acute pain setting can be very effective in reducing the amount of pain that people experience. Yeah.
Is it true or false that you can only experience one pain at a time? So if you have a throbbing headache, but you have a big bunion on your toe, the bunion might feel really good because the headache is more pronounced.
You can experience more than one pain at a time, but what you're describing is kind of like the naturally occurring form of what we do in the laboratory with cold water. It is possible that in some contexts, pain at one site may occupy your attention or clamp pain at other sites. But there are many people who have chronic pain. In fact, most people who have chronic pain have pain in many different areas, and they experience them at the same time. So you can experience pain in two places at once. Yeah.
Thank you very much for this talk. I'm curious, have you identified which gene affects political views? And if so, can you tell us about that gene?
No, I haven't. But it would be a great candidate for gene editing if we could find it. Yes.
Yeah. Last question. Then I'm going to ask.
What do you think about the advertising of different ailments you have on television? Do you have this third finger that hurts more than the second finger or whatever? And they make up these diseases for you to go buy something to help the pain. What do you think about advertising on television?
So I can see two sides to that. One is providing information to people can be helpful. And if there are new opportunities for them to better manage a condition that they have, that could be helpful. On the other hand, bringing people's attention to complaints that they weren't really aware of, and to treatments that they may not really need, could really cause harm. So there are two different kind of ways you could go with that, and I don't know what the right balance is.
Okay, this is great. And Roger will be coming for the other talks too, as much as he can. So if you still have questions, you'll have a chance to ask him. I have one question. You mentioned about brain imaging. Which part of the brain lights up?
Yes. So there are many different parts of the brain that light up. One set of areas are more sensory focused, like the somatosensory cortex, primary and secondary. The motor cortex often lights up because pain is there to motivate movement, right? To get away from whatever's causing the pain. And so the motor cortex lights up, but also some emotional parts of the brain, like the insular cortex, the cingulate cortex. But frankly, most parts of the brain can light up, partly because they're processing the pain and creating the experience of pain, and partly because they're trying to control the pain, the prefrontal cortex and those kinds of regions as well.
So can you use fMRI to grade pain, like you said, instead of an oral, asking the patient how painful it is? From fMRI, can you do that?
So fMRI can be correlated with how much pain people report, but it will never replace self-report, because how do you know the fMRI is related to their pain? Well, you relate it back to what they told you. So what they told you is always better than the fMRI.
Okay. There's some questions here. First one, has there been recent research on trauma experienced by one generation that may appear in some form in a later generation, a sort of genetic element? Not sure if it relates to experience of pain.
Yeah, so Dr. Cruz Almeida, who will be here next week, does work on epigenetics, which is one of the biological mechanisms that allows environmental stresses to be passed down from one generation to the next. And it could very well influence the experience of pain. So that's a very reasonable idea. I don't know of specific studies on trauma and epigenetics, but certainly a history of personal trauma increases the risk for pain.
Okay. And then there's a question, do you think testosterone or macho attitude might influence male pain acknowledgement? That was similar to Jeannie's question.
Yes, so that those sort of masculine gender roles are associated with reporting less pain. Now, testosterone separately has some analgesic effects, some pain-reducing effects on its own. Whether that has anything to do with the male attitude, or whether that has just to do with different biological processes, I don't know for sure.
And one last question is, I had a nerve damaged by an extraction of one of my wisdom teeth that causes chronic tingling. It has affected my speech at times. An oral surgeon offered to deaden the nerve. Do you know of options for this type of injury?
I am aware that that kind of injury occurs after oral surgery. I'm not a physician or an oral surgeon, so I wouldn't give advice. My general advice is try to avoid treatments that are irreversible unless there's no choice.
Okay. Well, thank you very much. This has been fantastic.
Thank you.
Wonderful.